So in clinical physiology, we have done pulse and blood pressure, but it should be if it is to be in a sequence, we should start with history taking and general physical examination. Introduction to the clinical examination, prerequisites is some explanation of some very common terms, common in the medical usage, and you should be knowing on the first day when you are dealing with clinics. You should be learning on the first day. You will again do it in your medicine clinics, but in the first year you just have a basic idea and concentrate on the normal findings, how to concentrate on the procedure. I repeat, in the first year of your medical school, concentrate on the process, on the procedure, not and basic findings. So we will examine, you will examine your maybe your own friends, own colleagues, and try to interpret what to interpret as normal and how. What is normal and how to interpret that. Like basically, if you see your friend, probably he or she is not anemic. So there is a that means there is a subheading. There is one characteristic called pallor, which is usually due to anemia. PALLOR. This is, I am just giving an example. So probably you will not find pallor in him or her, your classmate. If he or she is expected, we are not suffering from diseases. We are healthy subjects. So now here comes the question, some basic terms. What is the difference between a patient and a subject? I think I have told you at some point till we have done pulse and BP. A patient is in whom you have diagnosed something. There is an abnormality, there is a disease, or there is an abnormality, deviation from the normal. We use the term these patients and subjects interchangeably, but strictly speaking, subject, anyone who is coming to us, coming to the medical professional for clinical examination is the subject. Anyone who has been diagnosed with a disease or with some abnormality is the patient. That means with some medical abnormality, physical abnormality is a person, is a patient. What is the difference between a sign and a symptom? Basically, something the subject complains of and something the clinician elicits. Clinician elicits. How many of you do not understand Bengali? Okay. So try to get conversant with that. There will be faculties, some examiners will be there who may talk to you in Bengali. Just at least you should understand. But preferably we will always speak in English and try to communicate English, as the examiners are coming from all over India. And not only that, you have to communicate with the patient, with your patients also in future. But if the patients are, you are seeing local, like if you are from Bengal and seeing patients in Bengal and the patient does not understand, then you will have to be conversant with in the local language also. So this is somewhat tricky, but you have to do this. So we'll, in the classes and in the exams, we'll try to communicate in English. But remember, when you actually go to clinics, you may have to speak in Bengali also, where you, especially as a student, when you are communicating with the patients, if the patient is local, maybe he or she cannot communicate in anything other than Bengali here. So during the first year, you try to do everything, try to communicate in English whenever you are in this academic front, but there you remember you have to communicate in the local language. So within the first year of in the first year, you are not required to visit the hospital, very less, I think 1 or 2 times in community medicine, but not otherwise. So just remember this when we are talking of these clinics as a student, and in future will say that you have to get that you have to accommodate yourself, you have to adjust yourself like that. Okay, so coming back to the subject. So subject, difference between subject and patient, strictly speaking, difference between sign and symptom. Which is the symptom? What the subject complains of, or the subject tells you, or which you elicit as a medical professional? Which the subject complains of is the symptom. Like the subject will say, I am having fever, and you will elicit the temperature. Subject will say, I am having pain in the belly. he or she will not even say abdomen. Abdomen is a bit of an English term, a clinical medical, if even not a medical term, it is an English term, abdomen. So the subject will say, in Bengali, he or she will say, pete ব্যথা করছে, পেট में दर्द हो रहा है. And you will elicit what you will elicit by putting the palm over that specific area, or maybe you get it in other areas also. Like the subject will say something like, if you just suddenly put your hand over there where the subject is saying it is paining over here, you will say utter something like ah or something. So that is you are eliciting tenderness. Pain is the symptom, tenderness is the sign and symptom. So just now what we discussed it. Okay, nothing to write, you will get it in the books. SIGN sign, SYMPTOM is symptom, and patient and subject we just told you. Okay, next is, now these are some common terms, very common terms used, and that you will get across with. You have to get across with whenever you proceed for clinical examination. Next is prerequisites for any clinical examination. Prerequisites, what are to be ensured? So first is proper light. First one is proper light. You cannot examine your subject in a dark room where you can't see the subject can't see you. Okay, so proper light. Or even if you say the subject is someone blind or something, but you have to see. So proper light. A well-lighted room, well-lighted area, and mainly broad daylight is more preferable than artificial light. That does not mean you will not see your patients in the evening. Okay, then that is something else. But something like jaundice, you have already read about jaundice in your GI system. So yellowish discoloration of the skin or mucous membrane. So that is best or ideally examined in proper daylight, proper broad daylight. If not possible, then you have to see under artificial light, and again you have to re-examine. If say the patient, in case of an admitted patient, a patient who has been diagnosed with some abnormality admitted in the hospital, you have to again see in the daytime. If the subject is coming to you for one time, then you have to make a note that it has been examined. Ideally, you have to make a note, it has been examined not under artificial light. Because if it is very gross, like say, what is the definition of jaundice? It is above, bilirubin is above 2 milligram per DL of blood, per 100 ml of blood. When the yellowish discoloration of the skin or mucous membrane, when the serum bilirubin, SERUM, what is serum? Plasma minus some plasma proteins, that is fibrinogen. That is, we measure, this we learn in biochemistry, I think. We estimate these things in serum. So serum bilirubin is above 2 milligram per DL. That is laboratory finding. That we call jaundice. That means this happens when that serum bilirubin, if we tally, when we are examining a subject clinically and we suspect something, we send the blood for the test, investigation, lab investigation, we will usually see serum bilirubin is above 2 milligram %. So that is the definition of jaundice. So if it is very gross, say serum bilirubin is 16 milligram per DL, then even under artificial light we can see. That means very gross, very evident by just by looking at the subject. That is something else. But if it is just say it is 1.8, it is 2, so you will have to look for it, and that has to be done in proper daylight. So one of the prerequisites is, or the first prerequisite we speak of is proper daylight. Next is the subject you will enter, you have to make him or her comfortable. Okay, you have to you cannot say that you stand, there is nothing in the here, only the room is present and I have nothing for you, so you just stand, I'll stand and I'll do. So that is not, that there has to be a couch, because some examination you have to do general examination followed by systemic examination of the different systems, examination of the respiratory system, examination of the cardiovascular system, of which pulse and blood pressure which we have done is a part of general physical examination as well as examination of the cardiovascular system. So that is, you have to do examination of the abdomen, and as beginners you will learn to do everything, and then according to symptoms you have to, that means you have to apply your intelligence that this is to be prioritized more, that whenever a person is having cough and shortness of breath, you prioritize more the respiratory system and the cardiovascular system, and this will come by experience. When a person is having pain in the abdomen, so you have to examine the abdomen, examination of the GI system, examination of the abdomen. Okay. Likewise, this has to be learned by, as your knowledge goes on increasing and experience goes on increasing, you can do it by yourself. But ideally speaking, everything has to be examined, which is not always possible, especially in a country like ours when the doctor population ratio is so less. So you can't give 1 hour for every patient, every subject, every patient. But ideally, you should examine all the systems at least in short. So what is general physical examination followed by systemic examination? This is how to clinically examine a subject. So for that you need a couch. You need a chair. So you will see in your daily practice, sometimes you are not using the couch for every subject because firstly time is constant and you just apply your intelligence, it is not needed. It is not needed, but that you have to gain by experience. But while now learning as a beginner, you learn that you have to provide a area that he will sit in front of you or ideally beside you, so that you can just examine. You have to touch the subject also for examining him or her. So we'll come to the points, and we will know how to clinically examine. You have to touch the subject. So sits beside you on a couch. You may be the person accompanying the subject, you will be seated on a chair in front of you, just across the table like this. And when the couch is to be used for examining, so you have to make the subject comfortable by providing these things. If it is your own chamber, you have to make sure that these things are provided. Now, if you are in the books, it is written, next is in the books it is written, if it is for a female subject and a male, that means medical personnel, male doctor, there has to be a female attendant. Okay. So I say it as, so these books have been written, books are being written by senior faculties, senior persons in physiology, senior persons in medicine. They have described it like that, and earlier it has been described like this for ages, and earlier it was that very few female doctors. So just to deviate from this subject proper, I went to the book fair that day last week. So I just purchased a book. I have not got time to read till now, that Lady Doctors in India. So who was the first? So it is given right there at the entrance of the physiology department. So very few lady doctors were there earlier. So the books have been written like this: the doctor is supposed to be male, and if there is a female subject, you have to keep a female attendant, but the opposite is true. And I will give you an example from the story from not a story, actual fact from my own life, that I was having a very fast heart rate while working as a house staff in the anesthesia department at medical college where I studied. Then after completing internship, I was a house staff in anesthesia department, and one night, it was about 11 p.m., 10:30 I think. I just had dinner and came back. We used to have 8 to 8 shifts. That means the night shift was 8 to 8. And throughout the night, it is RG Core Medical College actually. So it is the gynecology and obstetrics it is the regional center in Eastern India. So we have had you don't have an idea what is the actual normal number, but as high as in 12 hours, 36, I have seen. I was a house staff in gynae department also for this gynae and obstetrics also for 3 months before that. So I have seen 36 vaginal deliveries and 16 cesarean sections occurring on the same night. So it was a very busy those days. It was somewhat less busy in these winter months, but say June, July to up to November, it was too much of work to do. So I just had my dinner break, 30 minutes, and came back. Suddenly I started having a very fast heart rate. So there was one senior person with me, I think some madam MD anesthesia. So just she said, okay, I am taking care of it. You just go to the, can you go yourself? I think one staff accompanied me or something. Just across the other side was the, just not road, that is within the campus only, was the cardiology building. So I went there, and what happened actually, the RMO on duty on cardiology that night was a lady somewhat 2-3 years elder to me. And so after say 10 minutes, I was just lying on the couch, and the lady just came, and I had to, that means I had to undergo a ECG right then. Why? The heart rate is like 180, say, and it was not coming down by itself. So we have already learned body has certain physiological mechanisms. CVS theory has been done, but it was not coming down. It was like that, and I could feel it, that it is going on 160. I was having no other problem, but I was not having sweating. So possibly it is not a case of myocardial infarction, which you like. You have been taught myocardial infarction also. ECG changes in myocardial infarction. So probably it was not myocardial infarction. I was not sweating and all. You will learn this in medicine. So what are the other symptoms you will get? But only fast heart rate. Okay. So blood pressure could be measured, but I am telling actual facts from my own life. So blood pressure could be measured, but for taking the ECG, obviously clothes have to be removed. And this lady doctor, after 10 minutes, she asked me, if you don't mind, can I do it myself, because the male staff will accompany me, has gone to dinner. Then I say, of course, madam. So I am working over here, I have no reservations, you can do it. And maybe there will be another female, the nursing staff will be beside there. And I say, I have no reservations, madam, please do it, because it is for my own good. So she was hesitating. She was hesitating that I don't have the male attendant. So just don't write or say like the books, male person, male doctor, female attendant. Write if the medical personnel and I have never told this story to the previous batches. First time I am telling while teaching this topic. First time I am telling this story. I have not. That means it did not come to my mind that I may utter this story, this fact also, that this has happened in my own life. So always say, if the medical person, I think you will not forget, at least after listening to this, if the doctor or the medical personnel, or you may say, or not only the doctor, if the clinical person, if the person who is in charge of examining the subject and the subject are of opposite gender, then one person, one attendant must be present who is of the same gender as that of the subject, or the medical personnel as that of the subject, So male doctor, female subject, it should be, or female nurse, male, ideally it should be a male attendant. But in our country, practically not always possible. So if the female nurse has to be accompanied by a male person for 120 patients in a single ward, it is not possible. So like that it is done, but ideally it should be so. Male doctor, female subject, female attendant should be there, must be there. Female doctor, male subject, male attendant should be there. So there are more prerequisites. So first is well lighted room, making the subject comfortable. This requirement of when the subject and the clinical examiner are of the opposite gender, and we should stand on the right hand side. So again we are assuming that all of us are right handed. So for a left handed clinical examiner, left handed doctor, he or she will find it comfortable to lie on, to be on the left hand side of the subject. And this is not always strictly to be followed, but most of us are right handed. So in the books it is written like this: stand on the right hand. If the suppose you are the person is lying on the couch, so stand on the right hand to examine. So if you are a left handed person, anybody left handed in this room? Left handed, the preferred hand is the left hand? No. So left handed, then you may stand on the left hand also. But again, here this is a tricky situation. To examine the liver, you have to do it from the right side with your right hand, even if it is not, you are not, so left-handed person means, or right-handed person does not mean he or she is completely unable to use the left hand, obvious. So liver, it is better to do with the right hand from the right side. It can be done, but it is better. Spleen, like that, right hand, you have to go deep in. How to examine the spleen? Examination of the liver and the spleen we'll do in examination of the abdomen, a clinical examination of the abdomen. So maybe in 2 weeks, 3 weeks time. Before that, respiratory, CVS, general physical examination, respiratory, CVS, then examination of the abdomen, maybe in 2 weeks time. Next week we'll complete CVS, that is pulse and blood pressure have been done. That is a part of general physical examination as well as clinical examination of the cardiovascular system, and whatever else is left in clinical examination of the cardiovascular system we will do in next week. General physical examination also I prefer 2 classes, but with time is short. This is the only class, we will revise later. So just I will tell you the points, but you go on practicing yourself at home. That is always recommended and must. Otherwise you will forget, you will make mistakes in the exam. After completing the whole clinical examination, CVS, respiratory, abdomen, CNS, okay, possibly many of you will not face questions from general physical examination. I am telling from the exam point of view. Many of you, maybe. Systemic examination you are being able to show satisfactorily, it's okay. But what will happen after completing all those things? That is huge. At least for beginners, that is a huge part. In physiology, examining all this and finding out what is normal and knowing how to, at least theoretically knowing how to differentiate with abnormal. So it is a huge thing, but we will try. We will, that means we will try. How we will try? That means you, I mean you as beginners, you have to go and practice at home. Pulse BP, BP you may say I didn't have there was only one class. We were tried to be quite lenient this time, as only one class on pulse and one class on blood pressure was taken. But examiners will not be so lenient. So suddenly if the examiner say pleases for one person, I will start with general physical examination, pallor, cyanosis, jaundice, clubbing, inhibition, and you cannot show it, you get 0 out of 20. He or she even may not proceed to anything else. Systemic examination. Show me, so systemic show me how to examine how to auscultate the respiratory system. So I'll come to these terms. What are these? Show me how to examine the breath sounds. Show me how to examine how to find if there is any enlargement of the liver or not from the examination of the abdomen. Show me how to examine gait. These are the questions. I am telling you some questions. You don't have an idea of these right now. How to examine gait. Gait means the manner of walking. This is in examination of the CNS. Show me how to examine for touch sensation in a subject. So from CNS. So before this, if the examiner finds out that you cannot just show what are the sites, or you cannot say what are the sites to examine the pallor or cyanosis or clubbing or jaundice, just he or she will, okay, your examination is over, just go away, put a 0 out of 20, and you at that moment you know that you have failed in your practical examination, because 0 out of 20 in after getting 0 out of 20 in this clinical part, it is very difficult to get 50 out of 100. So very careful. I'll discuss today and you just go on practicing. So general physical examination, before that I utter some terms. General physical, so we have already told the prerequisites. Right hand, stand on the right hand. Before that, well lighted room, make the subject comfortable. Requirement of attendant, of the same sex as that of the subject if the subject is of the opposite sex of that of the medical personnel. So these are the prerequisites. Now, general physical examination we study under some points because that is, I think it is suitable for the beginners, but just now before coming to your class as teachers you have to go through books you read before coming to the class also, because faculties are sometimes reading from the standard textbooks, mostly written by foreign authors also, but the books you are using, we go through those books also, that how they are writing. So just now I consulted the latest edition of AKJAN just before coming to your class. They are also writing like this. See, you can't make the subject feel disturbed. So both the two things, pallor and jaundice, both you have to see. Cyanosis also, you have to ask the subject to protrude out the tongue. This is just an example. I am coming to how to examine. So protrusion of the tongue by the subject is required for you to examine pallor, cyanosis, jaundice. Now see, if you, as beginners we study like these are the points. So how to show pallor? So as soon as the subject protrudes the tongue out, and you have to ask the subject to make the tongue backwards, okay. So to examine for this yellowish discoloration. So you do this at a go. You don't ask, okay, now I'll say, you don't think, and I'll see pallor, protrude out the tongue. Again, after 1 minute, okay, I'll have to see cyanosis. Again, so this is not the way. The way is, when you are examining the tongue, you examine. When you are examining the eyes, again, pallor and jaundice both in the eyes, you examine all together, eyes. So this is from head to toe you have to go. When you actually practice, actually do it. But as beginners, we study as points just this is for convenience of learning for the first time. Okay. So if you have to go from head to toe, you have to know 4 terms. 4 terms, that is inspection, palpation. These 4 are part of every. These 4 are required in every systemic examination also. So inspection, palpation, nothing to write, absolutely nothing to write. Writing down and then not following the book, that will harm you. Not practicing yourself, absolutely nothing to write. Given in every damn book on medical science, that means in clinical examination part. Physiology, medicine, if you can't see, I'll just inspection, INS. So this is the board is, sometimes the board is not working, sometimes these are INS, PEC, TION, English term for observation. That is good observation. You have to, just as the subject enters the room, this is your chamber, you are seated on this couch, there is a couch for the subject, say here, preferably on your right hand side. Okay, the subject is entering, you look at the subject, whether very lean and thin, whether very obese, these things. General observation has to be good. That is your observation. Whether the person comes and sits, you ask him or her age. So, okay, I have not discussed history taking. So, history taking is also mentioned in your syllabus. I'll just discuss it. Just know these 4 terms, inspection. When you ask the subject his age, but you see, say a 30-year-old person is height is 3 feet. So that you can see. You can also make out approximate age and the height. So if that matches or not, if the height matches or not, whether the person is very obese, whether the person is very thin, whether the person is having some very gross abnormality like a huge swelling on the forehead, that you can just make out when the subject enters. So this is without having to touch the subject, whatever is possible by observation, that comes under inspection. What comes under palpation is what is by holding or touching the subject. So palpation usually is done with the palm of the hand, with the wrist in a comfortable position, not just described like that. When you have to, how do you examine the pulse? So examining the pulse will require palpation. holding the subject's wrist are to be flexed, and you do it with 3 fingers. Usually when you examine other parts, so you have to do it with the palm of the hand, sometimes with the back of your palm, like we see for temperature. Temperature we notice like this, back of the palm on the forehead, like this. So this is palpation. Simple, by touching the subject conveniently, of course. And what I forgot to mention in the prerequisite, before touching the subject, you have to take the consent. This is another very important prerequisite I forgot to mention. I mentioned 4, this is the another one. This is nothing in order. So well lighted room, make the subject comfortable, take his or her consent, okay, and you have to talk to the subject also, that I will not, if the subject is not deaf, then you have to talk to the subject that I will not that is, you will I will not disturb you, or my intention is not to, so that you are having some my intention is that you are comfortable, but I have to touch you for eliciting certain things. So you take this consent, and then you touch the subject with the requirement of attendant or not, that we told, and then before that you have to be on the specific side, right hand side or left hand side. In most cases it will be the right hand side, so most of us are right handed. So these are that point, consent is very important. So inspection, palpation, obviously after consent. Percussion is, we'll do in the examination of respiratory system CBS, percussion is placing the middle finger of your less preferred hand. So again in the books it may be written, place the middle finger of your left hand and you beat the middle finger of the other hand on that. So this middle finger of the non-preferred hand, in books it may be written left hand, is called the pleximeter finger. All these terms are given in the books, nothing to write. Pleximeter, pleximeter, and this with which we do is the plexer finger. We will show it during the respiratory. So that is percussion. Keeping on one, that means the designated body part, like between the ribs, in the intercostal spaces, we keep this pleximeter finger, the middle finger of the, usually the middle finger of the non-preferred hand, and with the middle finger of the preferred hand, movement from the wrist, this is percussion. And auscultation is using the stethoscope. So these are the general physical examination, we don't use auscultation. Auscultation is restricted, or auscultation is for systemic examination. General physical examination, the points are there, except where using the stethoscope, it is in which part of general physical examination we will use the stethoscope. We just said blood pressure is also a part of general physical examination. It is not a part of, that means it is a part of CBS, but it is, before that it is a part of general physical examination. Except blood pressure, we do not use the stethoscope. Okay. So mostly inspection, palpation, not percussion, is for respiratory system and CVS. In general physical examination, we will require inspection, we will require to observe, we will require to touch. Inspection, palpation, and auscultation, that is not proper auscultation, but the stethoscope will be required during measurement of blood pressure. Okay. So these are the terms for systemic examination. So from head to toe, you require inspection and palpation mostly, and stethoscope not for auscultation, but for measuring the blood pressure you require the stethoscope, and wherever auscultation is required, stethoscope is required. Auscultation is a part of other clinical examinations, that means systemic, respiratory, cardiovascular, and examination of abdomen. So you hear the sounds in the, that is, you have already done the GI system in theory. Peristaltic sounds are heard with the help of the stethoscope. Peristaltic sounds, GI system theory is done. Okay. So just points which are to note. So you may, if it cannot be seen, I will repeat it for you. Built or physique, just I told the person is entering. Will this black be preferable? Is it legible now after writing in black? sometimes they say it as, so these are just common English terms. I say prefer this term, build. So in examination of the motor system under the part that is under nervous system, examination of the motor system, this will again be repeated. In general examination, you just note whether the person is very lean and thin, very obese, and when the person is entering, what else you see? We have already told. Gross swelling, okay, over the forehead, even if under whatever part is not unclothed part, whatever is bare body, in the person will having only the face will be uncovered, so any swelling on the forehead or the face or over the scalp or something, very gross. So these things, whatever you can note, as even as a layman, even layman will note this, okay, he is very obese. So that way, as soon as the person enters, you can note it, if that is very grossly abnormal. So that is, and now whether the person is lean or thin, whether the height and age still you don't know, but still you can get an approximate idea before. So that is the build, physique, nutrition. So this is the first point. And before going to the other points, history taking is again a very important part. It is mentioned in your syllabus. So I will just discuss it in short. It is not very, I don't think it will be very asked in very detail, at least in your physiology exam. You will learn from third semester onwards, but they have mentioned it in your syllabus. So history taking, for as soon as the person enters and sits, so what if you go in sequence, what will happen? The person is entering your chamber, the doctor's chamber. You will, I am saying it for a, say, outpatient's visit. So outpatient visit. So we have to modify it according to your, that means applying your knowledge and your experience for the inpatients also. There the person is not entering your chamber. You are going to the bedside where the patient, the subject, the patient is admitted. So this is the first point to note in. So again I say the points are just for our own convenience. That means convenience as a learner. There we'll examine, in practice you will do it from head to toe. What's the time? Okay, it's 12. 1 hour still left. Okay, so the points you will note for points we are describing or points we are classifying just for convenience as a learner. So till now, have you followed the class? Are you getting it? So this is not very difficult, but why I am going slow? Because probably this is one class for now, we may revise later. And again I repeat, from the examination, physiology examination point of view, if the examiner sometimes, if the examiner says here he or she has taken 5 or 6%, he or she has already taken the exam, you are the 7th person. Now the examiner, just his or her mood changes. Let me start from general physical examination. History taking, general physical examination. If you cannot answer, he or she may get that means very disheartened or very angry, whatever you say, and just throw you out. That he or this person does not even know about history taking and general physical examination, what to proceed for systemic field. So that is the easier things may sometimes land you in trouble, because you have just forgotten and you have not practiced. So comparatively easier. So first is history taking. So first, as history taking is mentioned in your syllabus, this is as soon as the subject seeks. So I think if there is already a registration done in the hospital, or if it is your own chamber, you have to ask the name, or if the registration is done, that will be provided in that sheet of paper brought in by him or her, or provided to you by your assistant or the nursing staff. In our OPD here, this is the nursing staff, they are handling these things. That OPD tickets, these registration papers are coming to them, they are providing to the doctor's table, calling the patients and asking the patients to sit. So already you have those, or if it is your own chamber, you are all alone, you should not be all alone. Why? You should not be all alone, because you don't know, you can't be male and female together. Either you are male or you are female, and the subject may be male or the subject may be female. So you should not be all alone. If you are male, you should have a female attendant. The subject is entering, you have to ask the name, age and sex, you can make out by yourself. But in case of these all these things, hermaphrodites and all, So even you have to take that history. So that is basic history taking. So name and age you have to ask, you have to write male or female, and sometimes you may come across this hermaphroditism, all these things. So all these are the first things. So patient particulars. First is patient particulars or the patient profile, patient particulars. Profile is a broader term actually. So what will be included? Name, you may already have it if you are working in a hospital setup. Name, age, sex or gender, and residence or address, not the full address, because why is address important? Why is address important? Oh, that is a very good answer actually. So in case of any emergency, not only that, from the medical point of view, in case of any emergency these days, phone number is important, not address. So communicating to the, and this is not a joke, just communicating to the phone number of the relatives, it is also taken. In our OPD it is mentioned, one mobile number is taken. That means I will communicate to that person, that I will have to inform about the patient. Say in case of death of a patient, I will have to communicate to somebody that this person has died, your relatives, you come to the hospital. Not only death, anything else, this medicine is required, okay, you have to procure it, you come to the hospital. So these things are there. Address is important, or the area, if not the address, again I will say house number is not important. Here address does not means I live at 12/1C this and this road, not that. Area, whether the person is living in a city or when the person is living in a slum. So if the person is living in a slum, a lot of diseases related to hygiene, okay, these things, that is why address or area of living, that is important. And occupation, there are so many occupational diseases. A person working in a coal mine may be suffering from some respiratory disease, okay, person working with silicosis, okay, yes, these things. So that is, so about these diseases you will read in, not only in medicine, in our preventive and social medicine also. So some things, so these name, age, sex, address, occupation, at least these things, these are the patient particulars, okay. So all these are important. Name is required, name and age. So age, sex, address, occupation, all are related, all are important from medical point of view. Like hemophilia, a person, a female will not suffer from hemophilia usually, mostly 99%. Hemophilia sufferer will be male, carried by female. So age, sex, occupation, address, all will be may be related to, these are medically important actually, okay. Name is not medical, obviously. Even if the person does not know his or her name, if the person is an orphan, if someone is from the road, maybe age, it is difficult to note the age also then. Unknown, abandoned person. Name is not important, name is just for identity. But age, sex, occupation, address, all are related to. So patient particulars are the first point in history taking. And then what happens? If the person can converse by himself or herself, in case of very small children or even infants, you have to take it from the mother. That is, what are the chief complaints? Chief complaints. So people will come, laymen will come and say a lot of things. So you have to make out what are the chief complaints. If the person can describe যে আমার জ্বর, in Bengali আমার জ্বরটাই আমার সবচেয়ে বড় প্রবলেম, মানে বেশি প্রবলেম, দুদিন ধরে জ্বর হয়েছে, সঙ্গে একটু গায়ে ব্যথা আছে, I am having a lot of fever for 3 days along with some body ache, some cough, or whether the cough is more irritating, I am having a little fever but mostly cough. So what are the chief complaints? Write 2 or 3. Chief complaint should be 2 or 3, not 20. And then there will be associated complaints. Chief complaints, associated complaints. So you don't have to write like this when you are actually practicing. So fever is the chief, body ache is associated, not like this. You have to just note, you have to write that first followed. Fever for 3 days along with mild cough without expectoration. Expectoration is whether the cough is this sputum, this expectorant is coming out, or that is called the expectorant, that mass, that semi-solid liquid, not solid, semi-liquid mass like this, that is coming out or not. It is, and the character of that, yellowish. So chief complaints along with the characteristics of those, any characteristic which is associated. So cough with sputum. So whether the sputum is yellowish or whitish. Yellowish usually, that is dead bacteria. That means already the body is processing, neutrophils are killing those bacteria, those are also coming out. So that is a, say, 3 days, and the infection may have gone to a moderate to severe level. So fever with cough, or whether cough is more dry cough, no expectoration. So dry cough for 5 days, or it may be recurrent dry cough, that I had it last month also, before that also, chronic dry cough. Sometimes I feel feverish also. So which is chief? Those should not, usually that is not 15 in number, that is 2 or 3, and associated complaints. So you don't write this chief, or you sometimes we write CC, chief complaints, C/C, chief complaints in short, and also complaining of, also C/O, also complaining of, or sometimes we directly write C/of, complain of, or sometimes history of. Sometimes we have to write like, start writing like this, known case of, because known case means the person is coming, what you are having, sir? I am having nothing right now. I am having nothing right now. I am a diabetic, I am on medications, and I have to say, you are seeing him or her for the first time, but this doctor is not available right now. I visit that doctor regularly, and he had asked me to do a blood test for fasting blood glucose and postprandial blood glucose profile, and visit him this month, but he is not available right now, she is not available right now, so I have come to you. So he will just produce the lab test. So no complaints at present, but I am using this medicine. So that is not, then you don't have to deal with some complaint right then. You have to just then investigate him again. You have to examine him whether is there is. So in diabetic patients there may be so many complications. You have to just examine him, and then write what you advise regarding the medications and all, and other advice following lifestyle and all, diabetic patients. So diabetic patients. So there is no, absolutely no acute, no sudden complaint, no recent complaint like this. But in most cases there will be chief complaints, that I am having fever, I am having body ache, I am having pain in the hip region. So old patients probably, so say spinal cord compression diseases, so they will have pain in the inferior extremity, pain in the hip. That is due to these nerve roots gets compressed in the spinal cord. So I am having I am having fever, I am having cough, I am having headache. Sometimes complaints may be vague. I am used to writing sometimes that I can't make out anything. The person is actually also, from you take history from the family member. Yes, she always does like this. She is at home, very boring life, say, and nothing to do. Sometimes visits the doctor and just speaks out, I am having headache, this is not decreasing, I am having sleepless nights. That is actually not physical, more of these psychosomatic symptoms. This we will learn in medicine and psychiatry, psychosomatic symptoms. So there you have to write complaints are vague, but still you have to provide him or her at least some counseling you have to do. Okay. Even as a general practitioner, before sending directly, oh, you are having, so I find that you are having vague complaints, psychiatrist sitting right over there, he or she will tell you, I am paying the psychiatrist 1,000, so you are getting 500. That's why you are sending him. Already he or she is suffering from some no physical abnormality, psychosomatic symptoms, then directly he will point out at you that you are sending me there because I will give him 1,000, he will take 200. So you have to note those, but usually in case of actual physical complaints, there are some chief complaints followed by followed by, we tell it as present history, that what is happening recently, and past history. Now like this will come to you by experience. So present history, chief complaints, and past history is whether the person is diabetic for 5 years, whether the person is hypertensive for 3 years. So this comes under, and whether the person had an major surgical intervention how many years ago or how many months ago. Like one lady came to me yesterday or the day before yesterday, I think, or the last week. Okay, after having learning so many things, just pointed out, and that was not related to her present complaints also. I have a 45-year-old lady that I have undergone hysterectomy 3 months ago. So has that something to do with my present situation? I said no. But you visit the gynae and obstetrics department if you feel any problem about that. But your present complaints, now what is happening is not related to your hysterectomy just done 3 months ago. So but ideally, so here in actual practice, what happens, we do not find 1 hour for every patient. So that was not related to that. But ideally, I should have asked that by myself, that where some surgical intervention in the past few years or in the past this year or long ago also, whether had you a long history of some, say, you just the subject produce a chest x-ray and you find some shadows. So you will just suspect in your mind that this person has suffered from tuberculosis and that fibrous tissue this will go on remaining for the rest of his life. Whenever he will have a chest x-ray, this shadow will be there. So when did you suffer from tuberculosis? If so, when? So this is past history. Whether many major medical history of being admitted in the hospital for say 1 month, malaria or some childhood disease, whether I am suffering from asthma, childhood asthma is common in our country. So whether you had it from your very tender age or you are having this for only 2 years, say a 40-year-old person. So these things, present history and chief complaints, along with present history followed by past history. So chief complaints, present medical history, chief complaints and present medical history are somewhat related, but chief complaints will not be 20 in number. Present medical history, the person may go on uttering 10 problems. But then you have to apply your experience and knowledge that what is more important to interpret in this case, or interpret you have to do. So that comes by experience of the medical that is of the doctor. Present medical history, then past medical history, then personal history. Personal history is mainly, or we use it interchangeably with addiction history, right? We usually use it interchangeably, but personal history is a broader term. Addiction history, chronic smoker, COPD related, lung cancer, chronic smoker related. So I have smoked. Usually you will find patients, do you smoke? No doctor, I don't smoke. So you don't smoke. So today there are persons who he or she has smoked till 5 days ago, but still he or she will say, I don't smoke, I am not alcoholic. So in your medical profession, there is a very common statement, alcoholics are liars, and all alcoholics. So pancreatic diseases, okay. So what is A of pancreatic disease? A is alcohol and B is gallstone, right? When you read in surgery, pancreatic disease, CA pancreas, cancer pancreas, A is alcohol, B is gallstone, okay, 1 and 2. The 1 is alcohol, 2 is gallstone, and alcoholics are liars. So addiction history, so he has smoked or he has left smoking for 1 year. On a serious note, left smoking for 1 year, but he or she has mainly, again, there is a gender bias here. We take for granted females don't smoke, but this is not the situation anymore. In earlier, when you will be treating patients, when you will go after 5 years, after 10 years, after 15 years, and if I am alive then I will also face patients after 15 years, females having COPD. But nowadays mostly males, because COPD is more or less exclusively related, more or less. Again, more or less exclusive is an oxymoron. Oxymoron is, that is opposite words together. Exclusive means exclusive, more or less means more or less. So it is not exclusively, but it is more or less related to smoking. So he says he has smoked for 20 years, 20 cigarettes a day, and he has left it for 1 year. So that does not make any difference. Okay. So smoking, COPD or lung cancer. So that is personal history, addiction history. Okay. Chief complaints, present medical history, past medical history, addiction history. And I think this is not very boring. So you are learning from the first time, this is not very boring. This is interesting also. And if I mention it, if it is taught to you just without examples or without just these stories from the real life, these facts, then it is a bit boring, but it is not boring actually, it is interesting. So personal addiction history and then family history. So family history is more relevant for which types of diseases? Non-communicable diseases. That is I am sneezing, so I am suffering from common cold, I am sneezing, I have diabetes, it will not get to you. So respiratory diseases, communicable diseases may travel, these particles may travel through air and all, but diabetes and hypertension will not get, if I have it, it will not get to you just if I am sneezing in this room. So family history is important mainly for hereditary diseases, non-communicable diseases, family history. Okay, these are more or less the points for history taking, and any other points, any other relevant points. We may write it as any other relevant history, right? These are the points for history taking. So grossly, and in medicine it will be discussed in detail. When you go to the clinics, in clinical classes it will be discussed in detail, but they have specifically mentioned in one of the competencies, I think the last one, PY12 point something. There are 12, that means 12 sections in your syllabus, 12 sections of those competencies, like PY1 is for general physiology, PY2 is for blood, PY4 is for GI, like this, PY3 is for nerve muscle, PY5 is for cardiovascular physiology, like this. So PY12 miscellaneous, integrated physiology. So there they have mentioned, I think, general physical examination. So they have also mentioned history taking. I just saw it yesterday. They have changed it in just this September, this was changed. Late August, then there were some controversies and all regarding some topics in forensic medicine, hermaphroditism and all. There was some controversy. So ultimately I think on 29th August, they published the first one, and there were some modifications, and then it came out again on 12th September. There were those was revoked in 5th September, and then again the next week they modified those, and ultimately on 12th September, this 2024, the competencies you have to follow. Up to last year, PY it was 11 dot, integrated physiology was 11. Now they have made some topics have been, more classification has been done. So it has been done 12 sections, and PY 12.7 or something is obtained. That means learn about history taking and general physical examination. So history taking they have included, so I have discussed it in short. Now general physical examination, 1 point we have already told, just as the patient is entering, build. Okay, again this will not be helpful, this one, build we have already written, so I just remove it. Build, physics, nutrition, all these things in terms used interchangeably, though that is point number 1. Please don't talk among yourselves. Whatever that is very disturbing for the teacher, respiratory rate and rhythm. So these 4 I say together. I would recommend that these 4 you remember together. Everything you have to, that means every point you have to note. pulse, blood pressure, respiratory rate, temperature. Okay, why are you taking pictures? Why I am not writing these? Everything written in the book. But I just saw Ekejan latest edition. I saw you there writing that from head to toe. Okay, but you will get it. You will get books also. Okay, you may write down. Please don't take pictures like that in the class. You may write down like that. That build, pulse, blood pressure, respiratory rate, and rhythm, temperature. You will see. Just see the 8th edition of CL Ghai. I'll send you the PDF if you don't have it. And 10th edition, you see, it may differ. I don't know what CL Ghai. I have not seen that book yet. Earlier it was written like pulse for beginners, pulse, blood pressure, respiratory rate and rhythm, temperature. So it is sometimes instead of respiratory rate and rhythm, I think you will find respiration, but respiration is broad. Examination of the respiratory system is not a part of general physical examination. Total examination of respiratory system, including breath sounds with the stethoscope and all. Just you observe, inspect respiratory rate and rhythm. The person has to be exposed. Now I remember, I forgot another point in prerequisite. That is 5 points we have mentioned. 4 I had told, then consent I remembered later. That is exposure, proper exposure. Now I can't examine the respiratory rate and rhythm, I can't examine the CVS without exposing from, at least from the neck to the lower part of the abdomen, because respiration, respiratory rate and rhythm, respiration is thoracic as well as abdominal. The abdomen also moves along with the inspiration and expiration. So respiratory rate and rhythm, like pulse rate and rhythm, it is respiratory rate and rhythm. So pulse, blood pressure, respiratory rate and rhythm, not the whole respiration. So better to say respiratory rate and rhythm as a part of general physical examination, not the respiration whole. So in books it is written respiration, and inside they have written respiration, rate, rhythm. But it is, you just write the, or you just remember this as respiratory rate and rhythm. Next 5 you remember together, never forget. So 1, 4, 5, 2. So 1 is built on neck veins and neck lengths are actually you can write as 1 point. So 1, 4, 5, 1. So for those interested in football, 4, 5, 1 is one of the formations, right? How many interested in football? The game of football. So remember 1 built, after built it's 4, 5, 1. 4 remember together, 5 remember together, 1. Right? Neck veins and neck glands. So now I just mentioned in AKJ they are writing like this part, skin, neck is towards the last, they are writing according to the, from head to toe, the body parts, right? What you have to see in the fingers like that. In the fingers you have to note for cyanosis as clubbing. Okay. So what is cyanosis? It is reduced hemoglobin. What is cyanosis? Reduced hemoglobin greater than 5 gram%. Okay, first pulse done, blood pressure done, respiratory rate and rhythm you have to expose from. So one of the prerequisites is proper exposure. So usually the clothes have to be taken off. In case of if you are a male, the subject is female, or if you are a female, the subject is male. There a screen has to be put and the attendant will do these things. Attendant is of the same gender as that of the subject. Clothes have to be taken off and the person has to be covered by the gown, one gown, and then you enter the screened area. After the attendant has done this, you entered the screened area. The person, clothes have been taken off, the person is covered by gown, and now if you have to expose this chest and abdomen, now you have to, ask the person to take off the upper part of the gown also, like this. So during examination of the abdomen, even the genital regions are to be exposed. Abdomen not only means just the belly part, it is the external genitalia also. Then you have to, again, you have to tell that I have to examine the abdomen. So now the gown has to be taken off. But after, and when these things are being done, always the attendant will be by the side of the subject. In practice, if not possible, if it is actually not possible, if attendants is not there, so you are a male doctor, there the subject is female, at least one female relative of the subject should be there. Otherwise, it is not possible, at least in chamber practice in outpatients department. In hospitals, when you inpatients department, probably the female nurses will be there if you are the male doctor. And even if you are a female doctor, some male staff will be there probably. Although if you visit the government hospitals of our state or anywhere in the country, one ward, one doctor, one female nurse, say one male doctor, one female nurse, one ward. All up to this is one ward, one male doctor, one female nurse, 300 patients. So what will do? So these are challenges in practical life, but what is actually to be followed, that there must be the screen even in outpatients department. After the screen is there, you enter the screened area only after you enter the screened area, only after these things have been done. Clothes have been removed, gown has been put on, and now you will instruct, attendant will always be there. Okay, I'll have to examine only the respiratory. If you are doing general physical, you will just put on the upper part of the gown. Okay, like this. That is also you are applying yourself, that how you will do it. That is your choice, and you make the subject comfortable. You take his or her consent. These are also all prerequisites, and these come along together. Not that first point is well lighted room, second point. So you have to keep everything in mind while doing this. Make the subject comfortable. Take his or her consent. Then utter these words: "I will not hurt you. I will not hurt you." Just don't grab the collar or grab the person's hand and start examining like this. All these you have to remember. So, respiratory rate and rhythm, how it is done, usually it is better to note from the feet. So, the person is exposed from this, the neck, the chest and the abdomen are exposed, and what is covered, the external genitalia portion and the legs are covered. This is not required for noting respiratory rate and rhythm. So, obviously, so that even a layman can say. So, you look from the feet area, and now, but what happens during respiratory rate and rhythm, if the person is aware that you are noting his respiratory rate and rhythm, this may increase. So, one way is to do it from the feet, another way is to just acting. You see, you go to the feet area and touch the feet. Okay, I am seeing your, say you have already noted the pulse in the hands. Now I'll note the pulsation in your feet, because seeing the arterial pulse in the feet is also a part of noting pulse. So you act as if you are noting the pulses of the feet, but actually you look at the chest and the abdomen and note the respiratory rate and whether the respiration is regular or not. Right, this is how to note the respiratory rate and rhythm. And even if you don't go to the feet, you just note the pulse of the hand if you are in a hurry, okay, or if you don't like the patient, okay. If you don't like the patient, I will not give much time for him or her. So, if you are actually being negligent, then do that. So, ideally is not that, I am just joking. So, this is, if you are at the side of the patient and you are noting the pulse of the hand, so pulse you can count, you have counted the pulse, till you keep the hand on the pulse, and now you are actually counting the respiratory rate. You can't count the pulse and the respiratory rate together. Now you are noting the respiratory rate, but the subject is feeling where you are still seeing the pulse. So, respiratory rate and rhythm you note like that. Temperature with the back of your hand, usually on the forehead, and then with a thermometer. Right? Temperature. Now, pallor, cyanosis, jaundice, clubbing and edema, I will just show you directly. You just come forward and help me. Volunteer. So, all of you can see. So common sites, sometimes examiners, from the exam point of view, sometimes examiners won't may say, just ask verbally, tell me, because the syllabus is huge. I am saying from the exam point of view, CNS, CVS, SP3, abdomen, so many things. So sometimes examiners will just ask in the exam, will not ask you to show, but you have to know how to show. Tell me the sites for pallor, tell me the sites for examining jaundice, tell me the sites for examining cyanosis, and he or she may be happy. Then they just pass on, tell me. There is a difference between tell me and show me. Tell me the sites to note pallor, and then he just passes on, show me how to examine gait. Question from the nervous system part. Show me how to auscultate for breath sounds. So first question is, tell me the sites for pallor, you just say, and next question is, show me how to auscultate breath sounds. So then you are not to show the how to see, but now you have to know. If the question is show me, examine for pallor, then you have to show. Now what you have to do? Okay, I'll just examine you. Do I have your consent for that? I'll just examine you. Okay, I'll not hurt you. Okay, please cooperate with me. So these things always in general clinical examination, these things are common. Every time you have to say, not that before seeing pallor, should do you give my do I have your consent? Again, next point, do I have your consent? Once, just before touching or just before starting the conversation once, then you do, then you proceed. Sometimes you may require, like you will say a child is coming to you. In 5 years of life, he or she never had to visit a doctor. After he has learned, that means he has been self-conscious, he or she has been self-conscious. After you note for pallor and all, now you take out the stethoscope, the child may get afraid. Seriously, this is serious. The child may get, so what is the doctor bringing out? Now his or her mother is there trying to console him, nothing will happen, but you again say, ebar ami dekhbo stethoscope. So that is according to your experience, according to the situation what you are to do, but not like this that I see pallor. Okay, do I have your consent for cyanosis? Do I have your consent for jaundice? No. So first I'll examine you clinically, please cooperate with me. I'll not hurt you, please cooperate with me. Now during examination for touch sensation or pain sensation rather, we'll do in the CNS part. So you have to take a small pin also. So to say this pin is not for hurting you, but for mild pain sensation, I have to, whether you are, if the pain sensation is gone, then it may indicate so many things. If the pain sensation and pain sensation loss means it is actually disastrous. Disastrous. The person will put his or her hand in a burning oven and it will burn out and there will be no sensation. So to test pain sensation we require a pin. So then I may tell the person again that I will not hurt you actually. This pin is just for whether you can feel that mild pain sensation. I will feel for that. So I have to use this pin. This is not for pricking your finger and taking blood for blood tests, right? So that is the way. So I have his consent. Right now there is a male subject, I am a male person, even if the attendee is not there, I will start it. I have his consent. The room is more or less well lighted. So sites for pallor, first site is so this is the lower palpebral conjunctiva, So I will ask the patient, please look up like this. Please put your hands like this for me. You can show that you do this. Sometimes if the person is deaf, say there may be a deaf person coming to you, you have to rely on these things. Do this, the person will do that. Show me your nail beds like this, nail beds. So whether these are pale, have turned pale, or this reddish tinge, all of you see your own nail beds, these are there. Okay. So lower palpebral conjunctiva, so tongue, your tongue. So the whole tongue you will see. Now what I mentioned is, as learners we go by pallor, cyanosis, like as soon as the person puts out his tongue, you also see the tip of the tongue. You protrude your tongue and just hold your head, back of the tongue. You may use a torch over here for general physical examination. You keep a torch, you keep a stethoscope for blood pressure. Along with general physical examination, pulse and blood pressure, you keep a stethoscope, you keep a torch. You may, although jaundice is to be seen in proper daylight, ideally I should ask him to come over here so that this light is entering and see the undersurface of the tongue. So that is for jaundice. Now again I repeat, I don't ask, put out your tongue, okay, I have noted pallor. Okay, now put out your tongue, I note cyanosis. Not like this. As soon as he protrudes the tongue, I note for pallor, cyanosis, jaundice over there. And for jaundice in the eye, please look down, please look down. The upper palpebral conjunctiva, and if it is gross, that means say bilirubin is 10 mg%, 5 mg%. The sclera will be yellowish, whitish part. Sclera. You know the difference between sclera and conjunctiva. Sclera is the whitish part. Okay, cornea, sclera, conjunctiva. Okay, so upper bulbar, lower palpebral conjunctiva, upper bulbar conjunctiva. Please look down. So when you are examining the eyes, first you look for at the sclera. Please look up. Please look upwards. Yes. Please look downwards. Pallor, jaundice. Okay. Cyanosis, tip of the tongue and also the fingers and all. Cyanosis, I think it will be taught along with the respiratory system. Cyanosis theoretical part. So, bluish discoloration of the skin or mucous membrane when reduced hemoglobin goes above 5 g%. And explain why type of question in theory. In severe anemia, there is no cyanosis. In severe anemia, cyanosis, even if there is cyanosis, is not present. Why? Explain why. Because if hemoglobin level itself is 5 g%, how can reduced hemoglobin be 5 g%? It will be maximum 1 g%. If hemoglobin is at least 8-9 g%, there may be situations where it has gone up to 5 g%, reduced hemoglobin. That means deoxygenated hemoglobin. But hemoglobin itself is 4 g%. The person, it is 3 g%. The person is suffering from severe respiratory difficulties. The person may or may not live for more than 3 months. Then how there may be, you will note for cyanosis. This bluish discoloration will only be there if deoxygenated hemoglobin, which is blue in color, that means appears blue from outside, that is above 5 g%. So if there is severe anemia, there will not be cyanosis. But if the hemoglobin is 10 g%, cyanosis is due to some cause, and cyanosis is it may be only central or it may be central as well as peripheral. So central cyanosis, we note the tip of the tongue, one major, the mucous membrane of the lips, central cyanosis. Central cyanosis means it is not, this central is not related to the nervous system. Central cyanosis means due to hypoxia. So this comes in the discussion of the respiratory system. When oxygen is less in the environment, hypoxia. So cyanosis will be discussed after we discuss hypoxia in the theoretical classes. Central cyanosis, just for now, just you note the central cyanosis, tip of the tongue and lips of the mucous membrane. Peripheral cyanosis in the peripheral areas like the fingers and all, tip of the fingers and all. Clubbing is something, clubbing is defined as this loss of onychodermal angle. These definitions will find in books, practical books also, physiology practical books, medicine books obviously, but also physiology practical books. You see there is an angle. All of you look at your fingers like this from the back of the palm. Your name is Rajdeep. So, okay. So Rajdeep, also look at your fingers. So this you look at your fingers between where your nail bed is ending and your skin of the finger is starting, back of the fingers. This is not straight. There is some angles. This loss of, if this becomes straightish, this is loss of onychodermal angle. Again we refer to football. Only one person is interested in football in this room. Okay. Dada dekho football khala? Tumi? Haan. So only 2 persons. একজন স্টুডেন্ট হ্যান্ড রেজ করেছে 3 with me. Okay, loss of onychodermal angle is, as we see, not for offside in football. The referees or linesmen, nobody else. Football. Any of the girls? Again, there is a gender bias. Today, girls are interested more in cricket, but also in football. There is a rule called offside in football. So we can't see it from the front or the back. We have to, the linesman. Today we do not call them linesmen, it is the assistant referees. They look at it from the side. So they have to, for offsides, we have to note it from the side. Something called VAR has come into the picture for 2-3 years. Video assistant referee has to see from the side cameras. So football, it may be high side or low side, but it has to be from the side. Here you put it at your level of the eye, onychodermal. So this, whether it is straightish or not, as it is normal now, normal findings, it is obvious. You can note this angle either from statistics or from this. But when it will be, whether it is actually statistics, you have to look from the side like this and both the hands. And you see, one thing in clinical examination, you remember, always look for both. You see, okay, say pallor, okay, please cooperate for 2 more minutes, 2, 3, 4 minutes. Don't see like this. You are both hands. Now I examine, now I use both my hands together. Again, it will be disturbing for the subject if you see one eye and then go there and for the another eye. So, see both eyes together. So, clubbing, you put both the hands, and if you feel any difficulty as beginners, okay, you can see. Now, you just put above my right hand for you see, then left hand. You may do that. But whenever you are experienced, you see both hands. It will be good. It will be good for the subject. Okay. Although some subjects should be there in your actual practice who would like 30 minutes for him or her. Okay. There will be subjects waiting outside and asking your assistant, why is that doctor seeing the other patient for 20 minutes? Okay. Should have seen all those 5 in 10 minutes and then spent 30 minutes for me. So, there are expectations, but you cannot do anything about it. So, you are actually dealing with human beings, emotions, there are emotions inside you, emotions inside him or her, and when you examine, you not only you examine, you also speak. Like when you experienced, you are seeing pallor, but you are also asking about the past surgical history together. You don't have much time, okay. If you take 3 hours for 3 patients, so you go home, your wife will ask how much you have earned. Okay, I have earned only rupees 1000 in these 3 hours because I could examine only 3 patients, and you have also missed your son's birthday party. So everything is gone. Next day your wife leaves you. Right? So while you are taking history, you have already started general physical examination as your experience goes on increasing. And after 2 minutes, you write down these things. As you are seeing pallor, you may ask. You are noting because your eyes and ears are working at the same time, and it does. Okay. Sometimes these days are days of multitasking, and it actually does. So, these days we never, unless very engrossed, sometimes we are very engrossed, but I actually, when I am actually watching cricket or football, okay, I am checking your answer scripts also, and that won't create any, neither confusion in me, or that won't, like if my favorite team scores a goal, you will get more marks. That is not at least for me. So, you have to learn multitasking in these days. And jokes apart, this you have to do. When you are noting for pallor, you are talking to the patient so that he feels comfortable. That is the actual why you are doing this. So, pallor, cyanosis, jaundice, clubbing, edema is, already heard about edema in CVS. That means accumulation of fluid in the interstitial spaces. Now, this has to be shown lying down, the patient is lying down, and I have to over the medial malleolus. Medial malleolus, have you, infex is done? No. Started? Infex is started. Medial malleolus, you know what is the medial malleolus? Near the ankle, medial malleolus, just above the few centimeters above the medial malleolus, you take again 2 legs together, and you have to see whenever possible, you have to examine both sides. Now, obviously, when I am examining the external genitalia of a person, there is no question of both sides. Whenever I examine the liver, no both sides. When I examine the spleen, no both sides. Whenever I examine the heart, no both sides. But I am examining for edema, I have to watch for both legs. Okay. There is something called the jaw jerk, reflexes in CNS. So, biceps reflex. Biceps are muscles of the arms. Biceps reflex I have to see in both hands. But jaw jerk is in the middle of the jaw, no question of both sides. So edema I have to see on both sides. Just press it for the beginners, we say 30 seconds, 20 seconds, but 5 to 10 seconds are enough. So whether after pressing, when you release the fingers, whether the depression is automatically again depression is removed or depression is going away, or it remains depressed, that area. If it remains depressed, there is probably accumulation of fluid. There is something called pitting edema, non-pitting edema according to causes. You will learn in medicine, you will learn in theory, but just beginners, just basic how to look for edema like this. And this is, see, this is pedal edema in the legs, P-E-D-A-L, pedal edema. And next is, we can also, there is something called sacral edema. Again, it is not for, there both sides is not applicable. Sacral edema, just where the sacrum ends, have to expose, and just where the sacrum ends, at the lowest part of the vertebral column from outside, you just feel for the vertebral column and feel for sacral edema, maybe with your thumb, and there is no question of both sides there. Pedal edema is both sides, in both the legs. Neck veins and neck glands, there is something called jugular venous pulsation. Any grossly engorged veins in the neck or not, you just look at, okay, and from the front, from the back, from the sides, and there is something called jugular venous pulsation. We'll do it for you on Monday if possible, and if not, jugular venous pulsation, if you can take a separate class, it's okay. That is to be done with the CVS. But in the general part, general physical examination part, we just look for the neck veins like this, and neck glands, not only the neck glands, this under surface of this face near the mandible. In respiratory diseases, viral respiratory diseases, these get engorged. All these salivary glands and all, we can feel for them. Okay. So this is neck veins and leg glands just by observation. And jugular venous pulsation, examining the jugular venous pulsation is an important topic and somewhat tough, not very tough actually. That means it is one of the topics we may take a separate class for it, or it will be done along with examination of the CVS. It will be done on Monday then. So that is examination of jugular venous pulse, but it is neck veins, and in part of general physical examination like pulse, blood pressure is also with the CVS part. So these are the topics to note in general physical examination. I think you have only 10 minutes. So you practice it at home. We will revise this topic again later. Okay, just thank you. Thank you, Rajdeep. Rajdeep is from? Bolpur. So you are not living in a hostel? Okay, so that history taking. So again, just history taking. So prerequisites of a clinical examination. Well lighted room, then making the patient comfortable, taking his or her consent. If attendant is required, attendant is there, proper exposure, and from which side of the subject or patient, that is right side. Difference between subject and patient, difference between sign and symptom. Prerequisites of a clinical examination, history taking, that is patient particulars, name, age, sex, occupation, address. Then chief complaints, present medical history along with chief complaints, past medical history, personal history or addiction history, and family history, any other relevant history. And what is inspection, palpation, percussion, auscultation mainly required for systemic physical examination, but inspection, palpation also for general physical examination, and although not auscultation, stethoscope is required for measurement is blood pressure. And the points for general physical examination for beginners, built, then pallor cyanosis, pulse, blood pressure, respiratory rate and rhythm, temperature together, 4, 5, 1. Pallor cyanosis, jaundice, clubbing, edema, neck veins and leg glands. 1 plus 11, 1 plus 4 plus 5 plus 1. These are the 12 points. Or 11 points, 11 points for beginners, but actually in practice we do it from head to toe. Like if the examiner from the examination point of view, show me pallor, you have to look for pallor only. You see the lower palpebral conjunctiva, eyes, nail beds, tongue. But if you are actually doing it in practice, when the tongue is out, you look for pallor, cyanosis, jaundice, everything at a go. Otherwise, it will be very disturbing for the patient.